Welcome to the AHRQ Safety Program for Improving Antibiotic Use presentation on the role of the bedside nurse in antibiotic stewardship interventions. This narrated presentation is intended for nurses who are interested in becoming more active participants in antibiotic stewardship programs. However, other members of the stewardship team who want to learn how to encourage bedside nurses to become active participants in antibiotic stewardship activities are also encouraged to listen to this presentation. Our objectives are to describe the importance of bedside nurses in furthering antibiotic stewardship goals and to discuss specific examples of how bedside nurses can be involved in stewardship interventions. As a reminder, the goals of antibiotic stewardship are to ensure that all patients who need antibiotics receive the right drug at the right dose by the right route for the right duration, and to avoid the use of antibiotics when they are unlikely to improve patient outcomes but have the potential to cause harm. The Joint Commission recommends that inpatient antibiotic stewardship programs have multidisciplinary involvement. Most of the focus until now has been on the role of pharmacists and physicians. Even though bedside nurses administer antibiotics and monitor patient outcomes, the role of nursing in antibiotic stewardship interventions has largely been overlooked. However, bedside nurses are an integral part of clinical care teams and are often the patient's primary advocate. They should be viewed as valuable partners in antibiotic stewardship efforts. There are almost 3 million registered nurses in the United States. Even though they are likely participating in many stewardship-related activities already, nurses are often not formally integrated into stewardship programs. Nurses provide continuity of care and are vital in ensuring that goals of care are carried over and addressed on a daily basis. Nurses monitor patients 24 hours a day and are in an ideal position to assess responses to antibiotic therapy, changes in the clinical status of patients that may be suggestive of bacterial infections, and antibiotic-associated adverse events. Furthermore, nurses generally have close relationships with patients and families and can alleviate concerns about antibiotic use as well as assist in situations where patients have concerns about why they are not receiving antibiotics. This slide provides an overview of roles that you, the bedside nurse, can play in improving antibiotic use. First, you are key to ensuring timely administration of antibiotics occurs. If multiple antibiotics are ordered for a patient, you should clarify with the prescriber in which order the antibiotics should be given, based on what the most likely cause of infection is. You can help reduce the collection of unnecessary cultures and Clostridium difficile tests and ensure that cultures and other tests that are needed are obtained using appropriate collection techniques. We will discuss this in more detail later in the presentation. You can clarify antibiotic allergy histories and assess for new antibiotic side effects, such as development of a rash, and communicate your findings with prescribers. Additionally, you can ensure that therapeutic drug monitoring for vancomycin and aminoglycosides occurs at the proper time and that drug levels do not continue to be obtained after relevant antibiotics have been discontinued. Furthermore, you can be vital in informing prescribers when a patient may be ready to have their antibiotics converted from intravenous to oral. You can be very helpful in prompting the use of a daily antibiotic timeout during patient rounds or some other designated time. You can educate patients about the antibiotics they are receiving, both in the hospital and at discharge. And if patients have additional questions, you can inform the prescriber or unit pharmacist. Finally, you play a key role in reminding the teams of any lines, drains, and Foley catheters in place in your patients. Let's go through some specific examples of how you can help. First, you can assist with the diagnosis and treatment of C. difficile infections. It's very important to document both the consistency and frequency of bowel movements so it is clear if your patient truly meets the criteria for C. difficile testing. Remember to document this information in the same place in patient charts so that it is easy for other healthcare providers to find. Avoid testing for C. difficile if the patient does not meet clinical criteria for C. difficile infection. The criteria includes at least 3 watery stools within a 24-hour period, unless ileus is present. Do not send form stool for testing for C. difficile. It is better not to collect loose stools or stools with a particularly unusual odor just in case the provider wants to see it, as it might lead to unnecessary testing. If a patient truly has a C. difficile infection, he or she will have further episodes of diarrhea. Confirm that the patient has not received a laxative within the previous 48 hours. If a patient has received a laxative recently, stool should not be sent for C. difficile testing. If a patient does have C. difficile infection, remind prescribers to discontinue antibiotic agents that are not needed. Fluoroquinolones, clindamycin, ceftriaxone, or cefepime have a high risk of causing C. difficile compared with other antibiotics, and they generally should not be continued if a patient has a C. difficile infection. Finally, it is not recommended that a repeat C. difficile test be sent while your patient is being treated for C. difficile or after the treatment finishes, as the test is expected to stay positive for some time, even after successful treatment. Repeat testing may just lead to unnecessary additional antibiotic therapy. Another condition that you can help with is asymptomatic bacteriuria. Asymptomatic bacteriuria is when a significant amount of bacteria and white blood cells are observed in a patient's urine, but the patient does not have any clinical signs or symptoms of a urinary tract infection, or UTI. The bedside nurse has a very important role in avoiding unnecessary antibiotic use for this condition. First, urine cultures should not be sent if the patient does not have symptoms suggestive of a UTI. Fevers with other localizing symptoms to the urinary tract, such as flank pain, dysuria, frequency, or suprapubic pain, are all suggestive of a UTI. Fever in the absence of the rest of these symptoms in a patient able to acknowledge symptoms does not warrant collecting a urine culture. Remember to follow institutional protocols on correct collection of urine cultures. You can educate patients and families about asymptomatic bacteriuria. Educate families that foul-smelling or cloudy urine alone does not suggest a UTI. Educate families that asymptomatic bacteriuria is common and may be protective for some patients. Remind clinicians and families that yeast, such as Candida species, in the urine generally does not require antifungal therapy. Remind clinicians that urine cultures do not need to be sent routinely on admission, preoperatively, or routinely before or after a catheter change. Finally, avoid sending urine cultures as a test of cure after a patient has shown an appropriate response to antibiotic therapy. You can also assist with obtaining sputum cultures. Avoid sending sputum cultures if the patient does not have signs and symptoms suggestive of pneumonia. These include new onset fevers, shortness of breath, and/or new oxygen requirement in the setting of chest imaging findings suggestive of pneumonia. For ICU patients, do not collect sputum from the endotracheal tube unless there is a clinical concern for pneumonia. Remember that organisms are light growth, or less than 100,000 colony-forming units per milliliter, by endotracheal aspirate generally do not need to be treated. Also, remember that enterococci and Candida species are often isolated from the sputum, but are usually contaminants and should generally not be treated with anti-infective agents. Approximately 90% of patients who report allergies to penicillin have negative skin tests and are not at increased risks of an allergic reaction. If you are interested in learning more about penicillin allergies, consider watching the presentation titled Approach to Patients Reporting Penicillin Allergies on the AHRQ website. Clarify what patients mean when they state they have a penicillin allergy. Documenting these findings helps ensure patients don't receive medications that are not safe for them and also don't receive suboptimal antibiotics because of unnecessary drug allergy labels. Make sure prescribers know where this information is being documented and maintain consistency with where this information is documented in the medical record. Some of the questions you can ask to clarify your patient's antibiotic allergies include: how long after beginning the antibiotic did the reaction occur? Was there any wheezing, throat or mouth swelling or urticaria? If a rash occurred, where was the rash and what did it look like? Was the patient on other medications at the time of the reaction? Since then, has the patient ever received another penicillin or cephalosporin? Ask specifically about amoxicillin and brand names like Augmentin, Keflex, Suprax, etc. If so, were there reactions to these agents? Notify prescribers when patients want to discuss potential allergies further. Finally, as the bedside nurse, you are likely to be the first member of the healthcare team to recognize new antibiotic allergies and side effects, such as rashes, gastrointestinal upset, and diarrhea. You play a critical role in starting the conversation about how to mitigate these side effects and whether different antibiotics are needed. You can play an important role in ensuring that vancomycin trough levels are obtained at the appropriate time by working with the phlebotomy team. If vancomycin has been discontinued, ensure that orders for vancomycin trough levels have been discontinued. If vancomycin has been discontinued and there is still an order for vancomycin troughs, request the phlebotomist hold off drawing vancomycin troughs until confirming with the prescriber that levels are still needed. If vancomycin troughs are sub or supratherapeutic, discuss the next steps with the prescribers before administering vancomycin. Ask prescribers what vancomycin trough goals they want to set. It may be helpful to record these goals in nursing notes or daily goal sheets and pass the information on in a report. The same is true for aminoglycosides, genomycin, tobramycin, and amikacin. You can also assist with ensuring prescribers convert antibiotics from the intravenous or IV route to the oral or enteral route as soon as possible when indicated. When antibiotics are considered to be bioequivalent, this means no significant difference in the rate and extent of absorption via the IV or oral route. The oral or enteral route is preferred. Some examples of bioequivalent agents are fluoroquinolones, clindamycin, trimethoprim sulfamethoxazole, fluconazole, and linezolid. Oral therapy, regardless of bioequivalence, may also be indicated once patients have received a certain number of days of parenteral therapy, particularly if the patient has improved. Patients with infections such as meningitis or endocarditis are unlikely to ever be converted to oral therapy alone. Remember to prompt teams when patients who were previously MPO are able to take other oral medications or food. There are some major contraindications to oral therapy, including the following: when a patient is MPO, including medications; when a patient requires non-invasive mechanical ventilation, such as BiPAP; when a patient is hemodynamically unstable and receiving vasopressors; when a patient is requiring continuous nasogastric suctioning; when a patient has severe nausea, vomiting, diarrhea, active gastrointestinal bleed, or gastrointestinal obstruction; when the patient is at risk for aspiration due to active seizures or decreased level of consciousness. When Staphylococcus aureus is recovered from clinical cultures, some hospitals do additional rapid tests to determine if the bacteria is methicillin susceptible or methicillin resistant. Sometimes these tests look for the presence of the MEK-A gene. The presence of the MEK-A gene indicates the isolate is methicillin resistant. The absence of the MEK-A gene indicates the isolate is methicillin susceptible. Find out which tests are used to differentiate MRSA and MSSA in your institution. If a rapid test is being performed, the results will be available sooner than traditional culture results. If an organism is identified as Staphylococcus aureus, you may know that it is MRSA within 4 hours, depending on the test used. Regardless of whether a rapid diagnostic test or routine culture results differentiate MRSA or MSSA, if Staphylococcus aureus is present and a test returns negative for MRSA, vancomycin therapy is generally not indicated. and if it is being prescribed, you may want to discuss this with the prescribers. You can also help by ensuring antibiotic timeouts occur on a daily basis for patients actively receiving antibiotic therapy. Antibiotic timeouts remind us to pause and discuss if any changes need to be made to antibiotic regimens. As the bedside nurse, you could prompt use of this tool either during clinical rounds or just one-on-one with a prescriber. Timeouts can be done using a paper tool or electronic tool. An example of a timeout tool is included with the other resources for this project. Once you are used to the questions on the tool, you can also review these questions verbally during rounds. Alternatively, questions on the timeout tool can be added to your daily goals sheet. Feel free to be creative in determining the best way to integrate a timeout into daily practice. This is a great opportunity to enhance teamwork among the clinical care providers around antibiotic prescribing. Ensure patients are aware of the names of antibiotics they are receiving in the hospital, as well as those they are being discharged with. Patients should know how many days of antibiotics they are continuing after discharge. Educate patients that if they develop any reactions such as rashes or diarrhea, they should seek medical attention. Assist patients with identifying which clinician they should contact should any issues arise, both related to antibiotic use or concerning signs and symptoms of worsening infection. Notify prescribers if patients have additional antibiotic-associated questions. For your patients being sent home with central catheters or midlines, ensure patients understand which prescriber will be managing their catheters and catheter-related medications after discharge. The bedside nurse is the most knowledgeable provider about existing vascular catheters, drains, and Foley catheters. During clinical rounds, remind the team about the existence of these devices and their current uses, and prompt a discussion about their ongoing need if you are not sure they are still necessary. Remember, every additional day a drain or catheter stays in place increases your patient's risk for infection. You could consider adding information about these devices to the antibiotic timeout or any daily goals form that is discussed during clinical rounds. In summary, bedside nurses are vital to promoting optimal antibiotic use in hospitals. As the patient's advocate, you should feel comfortable speaking up. Let your stewardship team know you want to actively participate in improving antibiotic use and ask how you can help. Consider assisting your stewardship team with developing local guidelines and educate other nurses about using these guidelines. Consider posting them in common work areas or break rooms. Work with prescribers to initiate daily antibiotic timeouts. You should also ask your stewardship team if there is a nursing representative on their hospital antibiotic stewardship committee, and if not, perhaps you could be the nursing representative. The findings and recommendations in this presentation are those of the authors, who are responsible for its content, and do not necessarily represent the views of AHRQ. No statement in this presentation should be construed as an official position of AHRQ or of the U.S. Department of Health and Human Services. Any practice described in this presentation must be applied by healthcare practitioners in accordance with professional judgment and standards of care in regard to the unique circumstances that may apply in each situation they encounter. Use of brand, manufacturer, or vendor names is for identification only and does not imply endorsement by the Agency for Healthcare Research and Quality or the U.S. Department of Health and Human Services.